Hello and a warm welcome to everyone joining today's Link and Learn session. I greatly appreciate your presence, especially since we're meeting later than our usual time. So thank you for taking the time to be here. Today will be the first of two Link and Learn sessions focused on community-led monitoring. This topic has been indicated as a topic of interest for many of our SSLN member countries, and we are excited to delve into it with your participation. What makes today's session particularly special is our collaboration with ITPC, who are doing great work in communities and in the community-led monitoring space. We extend our sincerest gratitude to the ITPC team for hosting this session. Before I hand over to our hosts, please take note of a few key points to enhance our session. Firstly, we have live interpretation, so please select your preferred language, English or French, at the bottom of your screen. It is crucial that everyone selects their preferred language. Secondly, may we kindly introduce ourselves in the chat. Please share your name, organization, and country. This helps in fostering a sense of community amongst us. Thirdly, during the presentation, if you have questions, please feel free to post them in the chat. Alternatively, you can wait until after the presentation where we will have a Q&A session. And to the fourth point, towards the end of our call, we look forward to hearing reflections from our country champions. We will be inviting representatives from the various countries with us here today to share their insights. And lastly, before you leave the call, please take a moment to participate in a brief poll. Your feedback will be very valuable to us, and it will not take you more than 5 minutes. Thank you once again for joining us, and I'm confident that you will find this session insightful. Without further ado, let's welcome our hosts from ITPC. Thank you.
Good afternoon, good morning, good evening, everyone. My name is Krista Lauer, and I am the Citizen Science Lead at ITPC, the International Treatment Preparedness Coalition. We have a great session for you today on community-led monitoring. I'm just turning on my camera for a brief hello so you can see me, but now I will turn it off for bandwidth issues, and I will begin sharing our presentation. Can I please just have confirmation that everyone can see my slides?
Yes, I can. Ghana.
Great, wonderful.
Yes, we can.
Thank you. So today we're going to be spending about an hour speaking about community-led monitoring. I'm going to walk you through the agenda, and then my colleagues will take over as we go through the presentation. So to begin, we will just introduce ourselves and tell you a little bit more about ITPC. We've already been through the framing and introductions from the South-South Learning Network. And our presentation today goes through 5 parts. We'll begin with an introduction to the principles of CLM and ITPC's model. And then ITPC's model has 4 parts: education, evidence, engagement, and advocacy. And we will have a brief overview of all 4 of those sections. We will take a 10-minute break for questions after evidence number 2. And then the remainder of the time after we've completed the 4th section will be for discussion, question and answers. Please, you can bring us country-specific issues or questions you might have that apply to your local work. And then finally, we'll have closing remarks at the end. And as the colleagues from SSLN have mentioned, some time for reflections from each of the 4 countries. And now, without further ado, I will hand over to my colleague, Jelena Bozanovsky.
Hi, everyone. Hi, this is Jelena, just showing my face. And I will also switch off due to the bandwidth issues. I'm based in Malawi, so our internet here is not the best. So yes, we will go as Krista said today. We will talk a little bit. We will introduce ourselves, ITPC as a team, and then we will set the base for the ITPC CLM model and major principles around which there is a consensus around the globe on what are actually the principles that lay behind the CLM as a model, activity, philosophy. So we can go to the next slide, and I can just start with the quick snap of ITPC. I'm not sure if everyone here on the call is familiar with ITPC as an organization. We are a 20-year-old issue-based global activist network organization originating from the ITPC, means International Treatment Preparedness Coalition, very, very long name, but basically reflects the origins of the conference that started 20 years ago by an activist who wanted to make medicine affordable to those who did not have access to IRT treatments. And since then, it has grown on many levels. Now we have regional partners, and it's a very global activistic network, but in a global team is actually very lean and a small team. You can see most of my colleagues here on this first slide. Next slide. Just wanted to quickly, you already saw Krista. Krista is leading our strategic pillar called Watch What Matters, and CLM is part of this strategical pillar. And then we want to thank Krista. She's based in Seattle, so it's very early on her end. It's 6 a.m. And also Nadia, another lady who is based in the same time zone. She is leading another strategical pillar under ITPC. It's called Building Resilient Communities. So building resilient communities very intertwined with the Watch What Matters. So we are working together. And CLM as a methodology, as a tool, is very, very intertwined in both of these pillars. Third pillar is making medicines affordable. And myself, I am based in Malawi. Like I said, I'm originally from Serbia. You can probably hear my Slavic accent, and I'm implementing projects under these strategical areas. And we have two more colleagues, superstars, experts on CLM. Innocent, who will be presenting today and sharing his knowledge and experience on CLM advocacy and engagement. And Nadia Perun. Innocent is based in Senegal, and Nadia, she is in Mauritius, and she is the data queen, and she will be sharing more insights on data indicators, qualitative and qualitative, and data analysis. I just want to highlight one more time what Krista already shared, and that is, if there are any burning questions related to KPs that we should know about, throughout the presentation, please feel free to put them in the chat, and then we can also tailor the presentation to actually address these issues. Then maybe some of your questions that might, come at the end of the presentation might be answered throughout the presentation, because we can move to the next slide. We will focus on we will focus on ITPC model of CLM. This is just to say that CLM is, as we see it in the core, a science-based accountability innovation that puts communities first. What does this mean? This means that those who are the most affected communities are the ones who are defining what the pain points are. The recipients of care, they're the ones who are defining what is actually, my pain point, and how can I make a suggestion, or actually how can I prove that this is my pain point, and how can I make the fact-based evidence and argument in order to improve and advocate for, tackling this specific issue. That's why we say it's a science-based accountability innovation that puts community in first, as opposed to traditional academical science. We can move to the next slide. This is also very kind of important snap to determine what CLM is versus what CLM is not, because not necessarily everything that is community-based. And as we know, there's a lot of activities that are community-based are necessarily community-led, right? And vice versa. So it's important to say the difference, because what is community-based can be led by many other, let's say, structures or actors, donors, facilities themselves, if they want to improve the quality of service, or the government itself. So difference between community-based and community-led. Truly community-led activity is led and ownership lies within the community. The same goes for the definition of what are we going to track? What is our pain points? What is that we want to actually gather intelligence and knowledge and facts about? So how do we define, who is defining indicators, the qualitative and quantitative indicators? So the communities are those that are actually in ownership of this whole data story, qualitative and quantitative. Then there's a difference if we do a one-time rapid assessment, for example, versus what is actually community-led, if it's a routinely reoccurring data collection. So we are doing that on a monthly or quarterly basis, or depending on the issue basis, but we're doing that on a regular basis in order to see what are the trends and how can we use this evidence in order to actually advocate for our case. And then data ownership. Who is the owner of this data? Who is managing the data? If the answer is the communities, then we have CLM. If not, that is then questionable. Again, we always like to say CLM is fact-finding, so finding the facts and not pointing fingers, not fault-finding. It's just evidence-based advocacy. So that's also the difference between maybe some other activities that can be more kind of political. And then, of course, what is the ultimate goal? The ultimate point of CLM is the change, is the impact, is the sustainability of that change. It's not like one-off change, but needs to be actually a sustainable change. So that is the ultimate goal, to improve a particular issue. And then, yes, thank you. Next slide. I'm not going to go through the whole definition. This is what I already just mentioned. We just want to say the co-creation part of the solutions are important, because when we monitor the pain point and then we actually have a solution for it, that's where communities also come as a co-creators of the solutions for a particular service, or if we want to improve specific care point. And then CLM is an evolving field. That means also it's not set in stone. It's an evolving field. It's been different now than it's been 2 years ago. That is a good thing. So approaches might differ. In the next slide, we can see the kind of ITPC approach, which is based on the four we can move to the next slide, on the 4 quadrants. And this is what we're going to talk about today. This is where you should think about your specific questions and some of the burning issues on the KP areas that maybe you might have in Ghana, Zimbabwe, Zambia, and Cote d'Ivoire. We always like to start with education, because do I even know what are my rights? Do I even know what is the science behind the disease I have? Do I even have this awareness, this knowledge? So this is where education, as Bernard Shaw said, education is the power. And we really believe in starting from this point, education, then we can assess what are actually the gaps. We cannot know what are the gaps without having this knowledge about what are we have actually the rights to. So Krista will go deeper into the education part of the CLM model. And then after that, evidence, which is collecting the data, collecting the body of knowledge, collecting documenting the experience, documenting the pain points through setting up what are we going to monitor, what is the most important, is less more, is more less. What are the indicators we are setting up? and then qualitative and quantitative, getting the whole story in order to move to the next quadrant, and that's engagement platforms. Nadia Perun will take us through the evidence part, and then we're going to with Inoson and Nadia Rafif, tackle some important platforms for specific KPIs that we can actually engage, community consultative groups, or they have different names in different countries where communities are represented, and they have equal right to present from this fact-based evidence, and then afterwards propose adequate solutions as well. And then we go to the last part in this quadrant is called advocacy. So we go to actually advocate to those who actually make decisions and propose solutions, and see what is the best methodology to actually achieve that, based on our context, based on our atmospherics. And then we can move. So we can move to the last part of this intro, and those are the principles that lay behind the CLM model. And then there is a consensus and agreement about these principles globally. Like I said, there was a conference last year in Bangkok where most of the representatives of implementing partners, donors, community representatives, government representatives met, and they agreed on certain consensus of CLM, which was great because that cannot be then questioned, right? And I mentioned most of them already during this brief intro, but we can move to the next slide just to see what are the top few of them that we agreed. Like we already said, community-led movement by those who actually are affected is number one. And then independence. We should be protected against any interference from, financial, programmatic, governmental, from the government, from the donors. That's, we are trying, this is how it should be. These principles we should stick to, even though in practice sometimes there are differences, but this is something we're aiming towards. And then ownership in every stage, like we said, identifying the gaps, in indicators, communication channels, methodology for, messaging from the data to the advocacy messaging. That's what the communities needs to decide. And then advocacy activities always should be included, because like we said, the ultimate goal is the change, is the impact, is the co-creation of the solution for our pain point. We can move to the next slide. Last few points: ethical data collection, very important within the consent, confidentiality, data security. We want data to be verifiable, reliable. We always respect do not harm principle when we are collecting the data. Data ownership, that's what we already said. In order for that also is that the data collectors should be part of the service users, of the recipients of care, or the service users. In that sense, they're part of the community, and also they should be adequately trained, supported, paid for this labor in a way that should ensure their independence as well. So that's very important, adequate compensation. And also what we notice, and I think on the global level, is CLM is always more successful and impactful when there is a own structure. There's kind of centralized community-owned structure. So there needs to be some type of structure, which we notice, especially if we compare programs, for example, with the HIV programs, where there is a strong identity maybe by KPs comparing to maybe malaria programs. So this structure, if we feel, also is very critical for success of the CLM activities. So this has been the intro part, and now my colleagues will go a little bit deeper, and I will check on the chat if there are any questions already. But over to you, Krista, now, and thank you I hope I did not go over my time. Thank you.
Thanks very much. Thanks, Jelena. So to bring it now to how do we actually do CLM? We're trying to be very practical in this presentation, and also recognizing that many of you are working on key populations issues. So now we're going to talk a little bit more about how do we actually do it. So the first question is, why does the ITPC model begin with education? I think when a lot of people think about CLM, they immediately jump to, okay, so we need to define indicators, we probably need to buy tablets, and we go out and collect a bunch of data. You do need to define indicators and collect data, but at the very beginning, don't miss the pre-implementation steps, including education. So education means, for us, starting with some science-based education. Does the community really understand the science of the transmissible diseases that you're looking at? And that could be HIV. HIV is one of the main examples we're using today, but it could also be COVID, malaria, diabetes, cancers, many different things. So the science of how it works, but then also the standards of prevention, testing, and care. Normally, those are set by the World Health Organization. So for example, do you understand how HIV works in your body? And then the standards of what does good HIV prevention look like? What does good treatment look like? And that really empowers communities to be more knowledgeable and ready to claim those rights from their duty bearers and decision makers. If you know, for example, this is just a frontline treatment and I need to get on third line treatment, you can only really have that knowledge if you go through the steps about the science and the standards. So from our perspective, this kind of education can be open to anybody, but we really want to focus on community-friendly scientific information. And for us, that means very clear, simple, and direct messaging. It doesn't assume any prior knowledge. And of course, it's tailored to the specific audience. So many of you are working on key populations issues. How do you tailor a presentation about, for example, HIV risk in the context of key populations? What kind of messaging matters to them? What kind of issues are relevant to their specific context? Depending on the knowledge levels of your groups, you can tailor this kind of education. So if you're already working, or if you are leading a network of key populations advocates who are already running drop-in centers in the context of HIV and are super knowledgeable about the science, you might be able to go to a level 3 in-depth version of education. If it's a group that's newly getting involved in advocacy and community work, you might want to start with some more basic or bite-sized information. And this is a resource that's on our website that is very helpful because it provides HIV basic education along these different levels. So some of the topics that are covered here, of course, are, why are people in my community still getting HIV? How can I tell if my HIV treatment is working? In the context of tuberculosis, how can I find out if I have TB disease? And you'll notice these are phrased more from an individual person-centered perspective, as opposed to, here's our unit on HIV transmission and prevention. We start from the question that you might more often get from community members. Why are people in my community still getting HIV? And then there's different levels, as I was saying, of specificity that you can go into. So the example here of level 1 is this: why are people in my community still getting HIV? Again, the question behind this is about prevention and transmission. But you can see it's a very, very simple, very clear explanation. It doesn't have a lot of technical terms. It's very straightforward. So people may not know how HIV is passed, and giving examples of the pathways of transmission. A level 2 level of education might be something more like this. So you can see this one has to do with HIV natural history and testing, and it's explaining how HIV takes over a cell. So there's an infographic that's useful, but we're not saying, for example, this is the genetic code that comes in and the RNA and the DNA and how they work. No, HIV has a special key to enter. Once inside, it unpacks its toolkit, inserts instructions, and then copies are made within the body. And then there are some key discussion points. And then level 3 style of education. This, for example, has to do with recommendations for first, second, and third line HIV treatment. And you can see this is way, way more specific, very technical as compared to the other 2 levels. But a reason that we might want to go in this direction, of course, is community members, as they're defining their pain points. One of those pain points might be availability of medicines. And when you're going to the clinic, are the products and technologies and services you need available? But going beyond that, are communities aware of the differences between the first and second and third line regimens? And then it can help you narrow down your monitoring to, are we monitoring specific medications, and which are there that meet the needs of our communities. So again, this kind of brings home why you might want to go into this level of depth. So this is another sort of infographic explaining routine viral load monitoring. And again, this is an issue that comes up a lot, viral load monitoring, including the turnaround times for tests. But do people understand why that test is important and why you need to get your results in a timely manner? And this sort of explains what kind of results you might get from a viral load test, and then the decisions you can make thereafter, which helps reinforce why getting that test done and getting your results in a timely manner really matters. So this education can take many forms. This is an example of something ITPC did. We made a COVID quiz that people could do online. A lot of people like trivia. They think it's pretty fun. Instead of sort of a classroom setting where everyone's sitting and listening, this is a way to go about it to make it a little bit more fun and more interesting. And you can see it's all evidence-based. It gives you an idea of how people have answered and gives you scientific information about the correct answer. The last slide I have here, or next to last slide, is really about education as new products and things come into the market. So this is an ongoing piece of work throughout CLM. If new technologies, if new forms of treatment, if new forms of prevention are coming online, we need to continuously educate our communities. So this is an example of CAB-LA, and these are some of the questions that might come up. What have you heard about it? What is it? Is there more than one injectable? How often is it given? And discussing those questions and giving communities evidence-based answers is a really important part of CLM so that we can have an evidence-based program. The last piece of education are the policy commitments and targets that apply in your setting. So as communities start to think about what are we going to monitor, what are our pain points, the other question is also what are the rights that we have in our setting that we are able to claim. So some of those in the context of HIV might be a national HIV and AIDS strategic framework, a strategic plan. What are the targets? So if we're saying we want to reduce new HIV infections by 75%, and this is an example of the framework from Kenya, how can you link that back to, are we getting testing services that are needed to, for example, key populations, sex workers, men who have sex with men and others, to help reach those targets? And the other framework that I want to put here, because it's relevant to our discussion, is the Yogyakarta principles. These are principles and state obligations on the application of international human rights law in relation to sexual orientation, gender identity, gender expression, and sex characteristics. So each country differs in terms of their law relating to the LGBTQI community, but there are international norms and standards that you can use to help advance your rights and claims, even if they aren't part of the law or framework in your local community. So with that, I will hand over now to my colleague, Nadia Pirin, who will take us through evidence. And then at the end of this section, we will have 10 minutes of Q&A. Thanks. Over to you, Nadia.
Thank you, Krista. And hello, everyone. Just a quick camera for a few seconds so that you can see who's talking to you. So I'm Nadia from Mauritius, and I will be presenting the section on evidence, which is one of the most technical parts of CLM. So we use frameworks. Next slide, Krista. So for all the part about evidence, basically we're asking the question, what are we monitoring through the CLM? And as usual, we can monitor hundreds of thousands of things, and it's important to be able to focus down. So that's why we're using frameworks. So one of the frameworks that's most commonly used and very useful is the 5 A's. So when we're monitoring health services, whether it's in terms of prevention, treatment, or care, we are talking about the 5 different A's. So CLM monitors availability. So do the services or commodities exist? And if they exist, are they supplied adequately? So for example, availability would be all to do with stockouts of commodities at the level of prevention and treatment. The second one is accessibility. So that's access to the different services. Distances, we're talking about traveling, we're talking about hours of operation, or, for example, referral processes. And this main objective is to make sure that the services are accessible by everyone. Thirdly, we're talking about acceptability. So here we're basically talking about the quality of the services and of the care. Stigma and discrimination, so are the services free of that? And are the human rights respected, promoted, and protected through these services? Fourth position, we have affordability. So as you can see, that's a little dollar sign. So we are looking at whether there are out-of-pocket spendings here, or whether the services require money, or are they freely available. Is the service delivery model efficient? And that's linked to the last one, which is it sustainable? So is the response sustainable? So affordability has got all to do with financial sustainability of services. And fifthly, we have appropriateness. So this is how much the services are tailored to meet specific needs, whether it's key or vulnerable populations, so by different type of populations, or are considerations related to gender or age taken into consideration in the different packages. So with this framework, you can go to the next slide, Krista. With this framework, we use it to define what we're going to monitor. And this next roadmap is how we're going to actually do it. So that these are the steps in generating evidence for CLM. So community-led monitoring. So we're starting off, and we're going to be going through these 5 steps in my reduced time here. So first of all, we're defining the strategic priorities for the CLM. And once we know what the main objective of the CLM is going to be, then we can select or develop monitoring questions, decide what's the approach to collect the data, and then develop all the tools or the processes or any of the equipment or material that we need. And lastly, only then we start collecting the data, and we use the evidence. So next, this is something that's very important, because in a lot of the CLMs that I see, we don't take enough time to do this. So instead of starting by thinking, what are the indicators that we're going to create, it's really useful to start off by saying, what are the CLM priorities? And the most easy tool to do this is a problem tree, as you can see. And this is an example from Jamaica, which we did together. And next, Krista. And when we were working together with 3 days workshop, we brainstormed together and got this out of the brainstorming. So you can do next twice, Krista. So when we were brainstorming, we understood that the HIV cascade had a very low viral load among people living with HIV. And when we went into the problems, what was the main issue is that the retainment in services, health services, was low. And once again, going further down, what are the underlying causes of this problem? So you have the whole list there down there. I'm not going to go through it because you're going to be receiving this PowerPoint. So as you can see, we work through a problem tree like this, and it's only at the level of causes that we start focusing in terms of what are the indicators that we're going to be doing. Next, Krista. And finally, no, one before. And finally, while we were doing this, so what does it give? It gives the objectives of the CLM in Jamaica. So by 2025, the objective of the CLM was to increase retention and care from 88 to 95% in a specific district of the country. So you can see how it's a very smart objective, and they clearly know where they're going. Next. And so how we define the indicators, once we know the objective, this is an example, once again, from Jamaica. So once we have the objective, we go into looking at the indicators, the areas that we're going to be investigating. We're going to be looking at how these indicators are going to be disaggregated, so by region or by healthcare center or gender or age or type of key population. Each time we're going to be saying what is the quantitative data source and what is the qualitative data source for the same indicator. So we know where we're going to look for this information, how often we're going to look for the information. So you can read through this once you get this PowerPoint. This is just an extract to show how once you have a clear framework like this, you can move forward. Next.
5 minutes,
And
Nadia.
so once you have the framework, you're going from indicators to data collection. So what's important here is that while you're developing this framework, you're talking about the resources. So do you have the resources to collect the amount of data at this specific frequency? What sort of qualitative data will bring more context to the quantitative data? And what type of data is actually available? And here it's interesting just to point out that quite often in countries there is already data available. The government has already got part of the data. NGOs might be having other implementing partners might have data. So this is the moment where you check what's already happening so that you don't duplicate, so that you can use the data that's already available and start an analysis and see what's missing and see how your CLM is going to complement what already exists in that data. So once you have the data collection, the data framework, you're going to be doing a data collection plan with all the sort of administrative stuff, where we're going to collect it, what authorizations do we need, anything to do with ethics or security. And at that stage, we're also developing the data collection tools, which can be quantitative or qualitative in forms of interviews or surveys or focus group discussions. This will really depend on your objective and on your indicator framework. So it has to be step by step so that it stays in line with your main objectives. And then you're finally going to be training your data collectors before you start the pilot project. And what's important here is to really take time and budget for good training of data collectors so that they're really at ease with this process and your tools have already been troubleshooted by them. Next. So the data collection is, like Jelena said, routine. And what's important here is to be really focused. Less indicators are always going to give you more manageable data. What's also important is to, as much as possible, be able to have a pilot on the data collection process, so 3 to 6 months to be able to evaluate and improve your process and make sure if the program is sustainable. For example, in Jamaica, they struggled to keep up with other programs during their pilots, so they knew they had to readjust their internal structure to be able to continue doing the CLM and all their other programs. Next. So this is just a picture of how the data then flows from the bottom. Once it's collected, it's going to go up towards the data supervisors who are going to do data verification, and to the implementing institution who is going to manage all the data entry, verifying the data, making sure that there's quality checks done on there so that the data is reliable, and they are going to then use this data to inform advocacy and collaborate with other groups like academic institutions or community consultative groups to be able to produce the advocacy afterwards, which Nadia will be talking about in the next part. Next. For data analysis, it is a very big topic. Very simply put, it is looking for trends over time. Are the results better than before or worse than before? By disaggregation, are the results good for everyone, or are there people being left behind? In comparison, are they higher or lower than the national average? So that implies, of course, that you have the national average data. And the process for data analysis is collecting the data, cleaning it, and then only you pass on to analysis and interpretation of data. So next, this basically looks like this. You have lots of data collection tools, lots of papers, a big database, as you can see, which is completely unreadable and undigestible. And the challenge in data analysis is to get from the database to clean data, which is already something that's more easy to work with and classified and all the errors have been removed. And then using the clean data, you're interpreting to get to the reports and the materials. So there's interpretation in between. And the last part is about visualizing the results. So you can see down on the left, it's much more interesting to look at that than on the top on the right. So next, just to conclude on evidence, what's important here is to always remember that qualitative and quantitative is the richness of CLM. It enables us to present a comprehensive and contextualized picture. So the idea is to get enough evidence to inform your advocacy, but also very practical changes in the HIV response. And that only comes when you have both qualitative and quantitative data. So lastly, I'm over my time. All this information is available online on an ITPC report that you can download and have a look at. Thank you.
Merci beaucoup. And I should also mention these resources are also published in multiple languages, certainly English, French, and often Spanish and Russian. So now I will pause. I know that was a lot of information, but I would like to invite a 10-minute period now where anyone on the call can raise their hand and ask a question about the presentation so far. And I might need help from my colleagues online to see if there are any hands raised, or you can just unmute also and ask a question.
There's a question from Melvin.
Please go ahead.
Thank you. My name is Melvin from Zambia. I want to find out from the presentation, I think they have provided very elaborate ways of implementing the CLM, but I want to find out specifically on the feedback mechanism for the CLM. How was that implemented in maybe Jamaica or other countries where this has been implemented, and what would be the recommendation for feedback mechanism for CLM? Over.
Thank you, Melvin. I'm just checking the feedback mechanism. At what stage? What do you mean by feedback? Between who and who?
The dissemination mechanism for the information that is collected at different levels, like how was that done from Jamaica and other places that they have implemented in?
Innocent will talk about that, Nadia, on the engagement part.
Yes, can we park that question, Melvin, and see if it's answered in the next presentation?
All right, thank you.
Good question, though, and it will be coming up. And we have more country examples in the next 2 pieces of the presentation as well, which might help bring some of these ideas home.
And Dr. Adingra has hand raised.
Please go ahead.
Oui, je parle français.
Ça va, on parle français aussi.
OK. Je suis de Preparedness de la Côte d'Ivoire. Je vois que dans le CLM, il y a une partie très, très importante qui est l'éducation, la connaissance des bénéficiaires, même pour faire le suivi. Est-ce que lorsque la société civile postule pour faire les projets de CLM, est-ce que le financement lié au renforcement des capacités des bénéficiaires généralement n'est pas inclus? On leur demande d'identifier les indicateurs, on leur demande de définir le système de collecte. En réalité, ce n'est pas la structure elle-même qui va aller collecter, c'est les bénéficiaires. Et le renforcement de capacité des bénéficiaires sur les thématiques pour lesquelles ils vont collecter n'est généralement pas inclus dans les financements mis à disposition. Donc, quelle approche de plaidoyer la ITPC fait pour intégrer cet aspect-là dans les financements pour faire le suivi dirigé par la communauté? Merci.
Merci beaucoup. Je vais traduire vitement en anglais. So I'm not sure how the...
C'est bon, il y a une interpretation bouton, tu sais, Christa. Donc, je pense que les gens ont pu écouter en anglais.
Okay, just to double check, those who only speak English, were you able to hear that interpretation into English from the question?
Yes.
Okay.
If you
Okay.
yeah, if you click on the interpretation.
Okay, great. Alors, moi, je dirais en français, c'est vrai que normalement, le renforcement de capacité ne fait pas partie du budget pour le CLM. Mais il faut plaider pour avoir des ressources pour faire cette sorte d'intervention, parce que sinon, le CLM elle-même n'est pas aussi efficace. Je ne sais pas si Innocent voudrait peut-être ajouter un petit peu par rapport à le pré-engagement.
Certainement. Je dois dire très rapidement, euh, une chose importante, c'est que dès le début, s'assurer que si les organisations communautaires, ou précisément une organisation communautaire, est host du CLM, elle doit s'assurer de renforcer les capacités de ceux-là qui participent à la collecte de l'information, s'assurer qu'elle a les bonnes ressources, entrer en interaction avec celles et ceux qui ont la capacité d'analyser les informations pour produire justement les importants. On va dire,
Merci, Innocent. On t'a perdu à la fin. Désolé, Innocent, on ne t'entend pas. I'm sorry, Innocent, we can't hear you. Your connection is getting a little bit bad. But maybe just to finish that, because we will go back to the rest of the presentations and we will get into some more detail. It is true that many CLM budgets don't include education, and they also don't include funding for pre-engagement with other partners. Governments can often be skeptical of CLM. No one likes to be monitored, really. Even if we're doing our own work, if someone is looking over your shoulder, it can be a little uncomfortable. So it's important to do briefings on CLM at the beginning of the process to make sure that everyone is on board. We have shared objectives, shared understanding of what we're doing. If your CLM budget doesn't have those funds, do what you can to come back to your funder and ask for them. Explain the process, why these pre-implementation steps, the education component is very key. And we wish you luck in that process. We can discuss strategies at the end Q&A. But in the meantime, I would like to continue the presentation and come over to the next section on engagement, which is Nadia Rafif and Innocent. I can see that Innocent's connection is a little unstable, so Nadia, I will hand over to you.
Yes, yes, I think Innocent will join again, but waiting for that, I'm going to jump in. So, of course, the objective is not only to have data, right? We want to do something with the data. So we need to engage with other members and other constituency. Can you go next, Krista? So,
I'm back.
You're back. Okay, please go ahead. Go ahead.
I don't know. Yeah,
We
I don't
can
know
hear you
what's
well.
happened. Okay, right, perfect now. All right. So it's just in link with what we said previously related to the data collection and analysis process. We need absolutely to think about the key users of CLM data, because they are the one.
Unfortunately, we just lost your sound again, Innocent.
Oh, it's a pity because we could hear him well this time. Did we lose fully Innocent or just the sound? No, he's here.
To connect with them, manager at facility levels. So interaction with health.
Innocent, désolé, on ne t'entend pas. Maybe Nadia, can I suggest that you continue presenting these slides? And if Innocent has a piece to add, he can come in.
Yes, of course, I will. So Innocent was saying you need to know who will use whose data, right? So health service provider, service provider, manager at facility level, manager at program level, technical partner, and ultimately, of course, recipient of care. So his point was you need to engage them from the start, right? You need to work jointly to use the data you are producing. Next slide. Sorry, Innocent. I'm discovering the slide when I'm talking, but the topic is familiar, so it should be okay. So again, right, data analysis, visualization, and communication. Community analyze their own data, their CLM data, and they present the finding to a larger group of stakeholders, right? They look at the trend together. Here we're talking about engagement of other party, right? You need to involve a partner from the start, and also regularly to look at the trends and already start analyzing the data. You don't wait the end, right, to engage with partner. So partner can be multiple, right? It can be academic, right, in your country. University are interested to partner with community and give expertise. Sometimes you have to ask for expert consultant, especially for the data analysis part, right? But we, of course, always encourage to transfer skill to community in country. And all those people should not work in isolation. They should use this opportunity to transfer skill, right? Ultimately, what we want is community partner being able, right, to do their own analysis and own reporting. So next slide. Again, the data we have are very rich. We have to present the data beyond the community partner. And oftentimes in many countries, it can take the form of a community consulting group or a steering committee, different, there is many different names for that. And the member of this group usually, and it's vary from country to country, it's really depending on who you want to involve and who will be, right, will have an input to the data. Usually it's 10 to 15 members. It's always best to constitute this group from the start, right? They have to be involved from the start. So it can be composed of representatives from normative agency like UNAIDS, PEPFAR, WHO, Global Fund, other government organization, right? Your National AIDS Program or TB or Malaria Program, representative of Ministry of Health. Of course, other civil society organization, right? There is a CLM key implementer, but usually they work with allies, right, in the country, with other member of key population, other member of women organization, people living with HIV, etc. And in some country, research institute or independent experts are also part of and invited to join this consultative group. And it's vary from country to country, but they can meet on a monthly basis or quarterly basis to review CLM data, like Nadia said, right? After the cleaning is done and that trend start to emerge, they can be presented to the group, and together they will decide what is a priority to look at. And again, what we want to do with the data is to change what is not working, right? So reporting alone is not sufficient. What we then need to identify is, here's a problem, we have the data to prove it, so what change can we make together? So next slide.
And just to add in quickly, the colleague from Zambia who had the question earlier about feedback mechanisms, this is a very key feedback mechanism, the community consultative group. And it is often up to the CLM implementers to craft and create the community consultative group. but you can also use an existing structure. If there's a CCM in your country, if there's other sort of policy review bodies, this is one of the key feedback mechanisms. Sorry, Nadia, next slide.
No, absolutely. Thank you, because I'm not looking at the chat. Thank you very much. And I want to insist here today, particularly on key population, because oftentimes they are not involved or not enough involved, right, in community land monitoring. And we know how it's important, right, to have the beneficiary and people, key population involved from the start in the whole CLM cycle. So, you know, you remember what Nadia said, right? Identifying the problem, and after deciding on indicator, the first phase is key. And starting from this phase, you need to have key population representative, right? Part of the discussion, because they know well what are the issues that are facing sex workers, people who use drugs, men having sex with men. Of course, it's all depending on what you want to particularly monitor, right? But usually it's very important that the list of indicators include also specific issues that are specific to key population. And it's not only the indicator, right? Key population and data collection tool. They also need to be part of certainly your community consultative group. And in many countries, we also see, of course, key population organizations who are leading the CLM effort, right? And it's remind me about the question on capacity building that our colleague asked a little bit earlier. You're right. All of that means capacity building of the different actors, and that's a piece that is difficult to be funded, but at least Global Fund recognize really strongly that building capacity of community organization and key population is key for the HIV response. So we should take this opportunity, right, to also build capacity of this population on community land monitoring specifically. So key population need to be involved also, of course, in the analysis and part of the group of the coalition, which will lead advocacy for change. And they also should be part of discussion to co-create and advocate for solutions based on the CLM results. So
5 minutes, Nadia.
5 minutes, yes, it's going to be quick, or even less than 5 minutes, I think, I hope. So, of course, there are many entry points for key population that you can leverage. As I said, right, the Global Fund, CCM, and include key population representative. You need to engage very early and directly with your CCM when we talk about CLM, because we see that many of the GC7 applications this time have included CLM, so that's a very good positive change. So CCM member, KP representative, civil society representative of CCM are a very good entry point to know what will be your CCM program in your country. And not only Global Fund and CCM, but also PEPFAR. And I will, if you can go to next slide, Krista. Here you can see, right, how it's compelling to have specific key population data, right? Like you have to disaggregate your data per population, depending on, of course, the problem you want to tackle. But here, for example, it's an example of HIV, an access to HIV testing service for sex worker in Malawi and priority population. So again, those data are key, right, when you want to make a change specifically to KP program or KP friendly services in your country. Next slide. I'm going to go quick. You know that CLM is prioritized by Global Fund. I just mentioned that. It's really like part of a very important part of community system strengthening. And you can see that Global Fund is dividing community land monitoring is also adding community-led research and advocacy, community capacity building, and community engagement. So this is part of this big piece of community system strengthening. Next slide. That I think I'm not saying anything new, right? The Global Fund country dialogue is a very important entry point for key population and other civil society to push for their own issue, including CLM. Next slide. And PEPFAR also, right? You know that in the last PEPFAR guidance, that CLM is a key priority activity that should be in the country operational plan of PEPFAR target country. And they require, and they are requiring that CLM activity include an explicit focus on key population, especially when it's not already the case. So again, PEPFAR plan are also an important entry point to push for CLM, and CLM specifically targeting key population issue. So in the guidance that are shared with the PEPFAR country, you know, it's really explicit that country need to ensure that people living with HIV and KP-led organization are among the funded monitoring organization, right? Like not only like participating in CLM, but being recipient of funds to be able to lead community monitoring. Next slide. I'm going to go quick here. Here I wanted you have that in hands when you will have the slide decks. It's basically disaggregate and explain all the stage where key population should be involved, right? Again, it's a kind of recap of what I just said. They need to be engaged in the CLM implementation from the start, right? From the definition of the question. They have to be there when CLM are presented to a community member. Next slide. Most importantly, they have also not only to identify main issue and indicator, but they have to be part of the recruitment, the capacity building. They have to be involved in developing data collection tool, and also on the, of course, data analysis, data sharing, and data for advocacy. Thank you. So I don't know if Innocent is back. Let's check.
We'll just do a quick voice check. Innocent, can you please come in? Alas, Innocent, if you are trying, we cannot hear you. So I'm going to carry on and present the advocacy slides. I'm not nearly as charismatic as Innocent, sadly. We were just together in Morocco, in Marrakesh, at the beginning of October for a Francophone CLM Academy. And he's a wonderful expert in addition to wonderful presenter, but I will do my best and he will chime in as we go. So with regard to CLM, I will say this is the entire CLM data journey for change. I will say most of the emphasis right now, including financing, is on the two middle steps, implementation and turning data into information. There is much less financing support and emphasis and attention on the final two steps here, the transforming the information into action and the impact, tracking CLM data use. But as Innocent is saying, let's have a critical look on these steps, because without these steps, CLM is just a data collection exercise. Our point is to use this data for change. So again, this is another way to look at the overall CLM process, starting from the need and gap analysis, asking communities what their pain points are, all the way through steps 2, 3, 4, where most of the attention tends to be. And again, at the very end, this part of sharing the information with those who have the power to make changes. The community consultative group is the instrument that we recommend. And then targeted action and co-problem solving for change. So for advocacy, why do we do this? When problems aren't addressed, communities need to escalate to advocacy. I think there's sometimes a belief in CLM that the data itself is so compelling, the data will lead to change. And that's not actually true. You actually have to plan your advocacy efforts. And the first step is defining who has the power to make those changes. So one example, we've got lots of examples coming up. One of our health centers that we've been monitoring in Malawi, the community was saying to us, you know, ART collection day is always Thursday. When you come to collect your medications, you have a different colored patient card from everyone else, and you sit in a public area waiting for your medicines, and it's super stigmatizing. Could we please have a more private area? And the person with power to change that was the facility manager, and we managed to share the data, and very quickly we were able to get a private room. So understanding who has the power to affect the change is very important. And for CLM, the advocacy tactics do really vary. They're not always the same. It doesn't necessarily mean first thing you do is take to the streets and you protest and you say, our health facility is no good. It can be a more diplomatic, relationship-based version of advocacy. You have tea with the person that you need to make changes, some citizen journalism, you know, some dialogues around a boardroom table at your CCG. There's lots of different ways to affect change. And we're also learning more and more that the data collectors themselves are very, very powerful advocates. They're going into the health facilities every month. They're making relationships with doctors and nurses and managers. They become trusted partners, and they can give verbal feedback in the moment about, you know, the data is showing these gaps. These are some of the facility challenges I'm hearing from respondents, and a lot of change can get done that way. Okay, a couple of things to think about in advocacy, and we won't get into it in a whole lot of detail, but who is your audience? What's their level of knowledge on the topic? You want to make sure your messages aren't too complex or too simple for who you're talking to. Messaging, many of us want to give like 10 messages. You have to really narrow that down to 1 or 2 key messages. Context-specific messaging is very useful so that it's situated to what context you're working in. Human interest, I will say data is powerful, but it's not easy to remember. Stories are more powerful than data. If you can include your data in a story, that is more powerful than just saying the average wait time at this clinic in the last quarter was 6.5 hours. You could tell the story of one individual who's had a long wait time and then add the broader data on top of that. Visualization is really important. Again, it's really hard to do a whole CLM presentation in just an hour or an hour and a half, but we have whole learning sessions on data visualization. And then dissemination. How are we getting this out? In the past, it always used to be we will write a report, but now there's social medias, there's radio programs, there's slide decks. And then what role do the communities play in the dissemination of the advocacy? There's a whole different continuum of influence to action. So we have to remember who the decision makers are and where they might be. So they can be aware of the CLM data. They can actually be influenced by the CLM data. They might use the data sometimes, but not always. And ideally, we're getting all the way to the right-hand side here of actually integrating CLM data on a regular basis for decision-making. I would say if you're having challenges with your local decision makers or governments about CLM, part of it is defending the credibility of CLM data and recognizing that as all of our budgets are shrinking, CLM data can help decision makers make strategic use of limited funds. We can tell you very quickly and pinpoint these are the main issues, these are the main barriers, these are the main bottlenecks. If you have to make a decision with less money than usual, CLM data is very, very helpful for that. Applying data to some of the potential actions. So what kind of findings are the most relevant when it comes to individuals and communities? These are some of the things that we already talked about in the AAAAQ framework. What services are available? Are there unauthorized fees? In the context of key populations, you know, you can always get support from lawyers to document human rights violations or formally engage institutions through legal and other channels. I'm going to go through these quickly as we are going to share the slides later. If you're a CLM data user, how can the CLM complement and explain gaps in program targets? And you can orient some communities to improve the awareness of various health issues and adjust and improve CLM. Again, civil society, community groups, lawyers, they can make use of the CLM data to further document the arguments they're making, for example, on human rights violations. CLM data, again, the qualitative and quantitative nature of it. If you're making an argument about discrimination against key populations, that's kind of a general statement, but you can back it up with your CLM data to say, in the last quarter at these 3 facilities, we documented 17 issues of discriminatory behavior toward key populations. We can also say that HIV testing rates among key populations have dipped by 10% in the last 3 months. Connect the dots between making use of the data and linking that to the defense of rights. Again, social and service providers can also make use of the data in different ways. Managers at a facility level, they can take some actions like training service providers on non-stigmatizing practices and people-centered care. Again, let's think strategically about who needs to hear this information, the message they need to hear, and then what actions can they actually take with that data. Managers at program and policy level, including M&E experts and technical partners and international funding. And again, just on the funding perspective, because this does come back to what if there's only funding for CLM indicator development, tablets, and data collection, but not for building civil society capacity. This is where we can make that argument with the CLM work, that you need to provide the funding to support the quality of existing services, but also to fund and strengthen the networks of communities themselves. You can't not support that network and then all of a sudden say, okay, we need your help in implementing this or driving demand back to clinics. We need to constantly be supporting community infrastructure. And again, the whole point of CLM is to achieve shared results. The final part of our CLM cycle is advocacy, and it only really counts if there's an improvement to services, programs, or policies. Here are some very concrete examples of CLM results. In Côte d'Ivoire, and I know that we have some colleagues on the call, CLM data was used to eliminate user fees that were being charged to people living with HIV. In part thanks to CLM documentation that user fees were actually being implemented, and it was causing a significant barrier to people seeking care. In Malawi, we managed to secure the expansion of working hours at public hospitals. In Mauritania, secured health commodity supply and access. In Sierra Leone, we were able to introduce differentiated service delivery to better reach key populations. In South Africa, including around COVID, we were able to help expand multi-month dispensing of PrEP. In Ukraine, of course, there have been many challenges with regard to human rights violations. We were able to provide direct legal and psychosocial support by documenting the scope of those violations. And in Zimbabwe, data was used to reduce the duration of stockouts. I've already given this example. Innocent could get into it in a lot more detail, but when we spoke about this at our last CLM Academy, this is a real example of a concrete example of change with regard to CLM. The identification that user fees were being charged, and then an official level from the ministry abolishing the use of those charges. And also this made the case for the credibility of CLM data. I know PEPFAR at the time was also wondering what some of the barriers were in the country. And when the team presented this data, PEPFAR actually went out and did their own data analysis as well and found that the community data was very much absolutely correct. And it built a lot of trust with regard to the credibility of community data. This is an example from Malawi. There was CLM data that was showing there was a negative effect on key populations' access to HIV testing services in the context of COVID-19. And when that information was shared at a ministry level, we were able to make the case for a key population focal point at each facility. So we could see very clearly there's a negative effect on access to testing services. We brought it to people who had the power to make a change. And now at each of the 14 monitored sites we have in Malawi, there's a key population focal point. So again, how do we link the data to the decision makers who can make a change and then get to an actual change that will improve services? And finally, where can you learn more? Please go to clmhub.org. That is where we have many technical briefs on specific CLM topics, everything from indicator development to data quality to CLM data use for decision making. We also have just launched a CLM library where we're sorting many different publications, not just from ITPC, but from partners around the world that are sorted into the 4 quadrants of education, evidence, engagement, and advocacy. And before I get to the question and answers, I just wanted to ask Ino-san one more time if you wanted to weigh in or if we can hear you. And for those on the line, please have your questions ready as we are about to come to you. But first, Ino-san, are you there and do you want to weigh in?
I don't know if you can hear me now.
Yes, we can hear you.
Okay, but I think you did it right, and we have short time, and we need to give, to have some interaction with the participant. But really, you did it right, and I just mentioned that it's important to have good quality data and information, and to interact with partners, because the result we have in Côte d'Ivoire is due to the quality of information, the credibility of our information. PEPFAR jumped in, and really, PEPFAR was instrumental in how to engage government in the elimination of youth. If we don't have credibility, if we don't have quality data and information, it will be challenging for us to push government to work on the elimination of youth. That's something important you have to keep in mind. So we can probably have interaction with the participant. Thank you, Krista, for that.
Thank you, Ino-san. And now let's use the remainder of our time for questions from the group. I'm going to ask my colleagues to help identify if there are some questions in the chat. But please raise your hand or jump in, and we would be happy to answer any questions you might have.
Chimika?
Thank you, and hello everyone. Thank you once more, very clear, and really appreciate the information that has been shared. My understanding now, but I think listening to the component of the evidence there, in terms of priority setting and doing the problem analysis, it appeared to me more like I can lead to some kind of a quality improvement project, and I'm glad to appreciate that through CLM, quite a number of evidence that has been generated from the interventions and the like have resulted in some policy changes, which is very exciting. But my question is, I know sometimes when you identify a problem or barrier, some of the interventions would go down definitely on some policy changes. However, the major stakeholder here that has got major influence in policy changes is government. Now, I just want to learn, did you have any instances where the intervention that needed government did not have a buy-in, or indeed they made recommendations, but those recommendations seem to be unpopular or in conflict with the government stance? Particularly, I'm looking at the issue about the key populations. Certain categories under key pop were in some countries discriminalized, but we know that for certain barriers to be overcome, there should be some policy changes. I'm not sure if you had any challenges around this, and I'm glad to hear how you navigated around them. Thank you.
Thank you very much. If I could just summarize your question, perhaps, before we get into it. You appreciated the slides on policy changes, but could we share any instances where the intervention needed didn't necessarily already have government buy-in or was unpopular with government, especially in those countries where key populations are criminalized and securing policy changes might be challenging? Is that a fair summary, Chamika?
Yes, thank you.
Great. Okay. I know Nadia Hafif has a lot of expertise in this area, and Innocent as well. How would we like to go about maybe start with Nadia and then over to Innocent?
Yeah, that's a very good and challenging question. You know, when you were talking, I was trying in my mind I was trying to remember if we had something very specific where CLM help us to lead to policy change, for example, regarding key population. You know, so I don't know if you have something, but I don't have an example that come up because it's quite right. It's on the long run, right? I think I'm sure and I hope there will be some example, right, that will come in few countries in the next year. I'm trying to remember, you know, I'm trying to think about Ukraine. And it's a pity our colleague from Eastern Europe is not here because we also have a colleague working in Eastern Europe and Central Asia implementing CLM in very difficult context. And there were just a conference with people who use drug and they were trying to see how community-led monitoring could also lead to policy change regarding people who use drug around the world. I don't have an answer. I don't have an example to show, right? It doesn't mean it's not possible. It means it's a long run work, right?
Yes, maybe.
Yeah.
Sorry, can I add into that? The slide that we showed on HIV testing rates among sex workers that had tripled after the COVID period. So we saw a dip during COVID, and then after COVID, they had tripled to even better what they were before COVID. And that isn't an example necessarily of a policy change or a law change, but it is a site-specific change, a district-specific change in that when the data collectors are sex workers themselves, they become natural advocates to frontline healthcare workers at the facility. There are relationships built, they are known, and it can improve services at a local level. I think sometimes there's a huge amount of pressure on CLM to be able to enact a law change like decriminalization of homosexuality, where that has been the law for many, many, many years in different countries. And as Nadia is saying, that is a very long-term objective. But I think CLM has the potential to collect data, to make small changes at site-specific level, at district-specific level, so that when that moment comes, when suddenly you have the right person who gets elected, or there's an important movement within the country, you can kind of seize on that opportunity. But also it's not a realistic expectation for any CLM framework of sort of like, what is your target? Like in the next 18 months, we are going to change the laws of the entire country. No, but the work that you can do now on CLM to document the extent of the barriers and to try and change some hearts and minds through the monitoring process, because it is a process of relationship building. I think there can be more impact there than we have been able to document just yet. And then, Innocent, I will let you come in if there's anything else to add, and then we should go to more questions. Thanks.
Well, we can come with Nigeria. I mean, you all know that Nigeria, we have a law against homosexuality, and it's very hard one. It's 20 years jail for anyone intervening on these issues. But they succeeded to come with the needs of key population, especially when we talk about men having sex with men, through the angle of public health issues. And they work strategically with UNS and with the PEPFAR representative. So we have some indicators related to this category of men having sex with men. We also have some other indicators related to sex workers and drug users. So it's how you manage to articulate the conversation related to health, public health issues, and to ensure that the community consultative group, you have strategic partners and government representative. That's where the conversation could be done. And then you have strategic way to overcome their barriers, as we said, to access to health services. So that's an example from Nigeria, and we can learn more about what Duran is doing and some other organization related to CLM there.
Thanks so much, Innocent. I can see there's a question in the chat, and then please feel free to raise your hands as well. So there's a question in here from Gaye Mubaye, who's saying, good evening to everyone. Thank you very much for the presentations. My question is relative to the experience in Malawi on the implementation of the key populations focal points at the 14 health facilities that you mentioned. Could you tell us more? We can definitely tell you lots more. I'm not sure what kind of detail in particular that you are looking for, but since we went through the slides quite quickly, I will say our implementation partner in Malawi is Manarella. I'm happy to connect you with them over email if you would like to ask some specific questions, but peut-être vous pourriez nous dire quelle sorte de détails vous intéressent maintenant par rapport à les populations clés à Malawi. Maybe you could add a bit more detail to the chat or unmute yourself and ask what kind of details you're looking for. Okay, we're not hearing the details yet, so I will just sort of say a general update. There's many different ways that you could go about if you've got data saying there are some barriers and challenges for key populations. It's a recurring issue at all of our health facilities. We talked about health facility managers can implement trainings and make sure that all healthcare providers have these skills and techniques to provide services in a tailored way. Oh oui, allez, merci Gaye.
Oui, allô, bonsoir, bonsoir. J'avais un souci avec mon micro. Je peux
Il y
poser
a
ma
pas de...
question?
Oui, s'il vous plaît.
D'accord. Alors, j'ai cru voir au niveau, pendant la COVID, il y a eu l'implémentation des points focaux population clés dans les centres de santé. Et ma question, c'était de savoir comment est-ce que ces populations clés ont été identifiées et comment s'est fait le lien avec les prestataires de santé. Vu que généralement, les populations clés sont généralement victimes de stigmatisation et de discrimination dans les centres de santé. Et on essaie de faire tant bien que mal des sensibilisations auprès des prestataires de santé. Mais est-ce que c'est possible d'avoir l'exemple de la Malawi? Comment est-ce qu'ils ont pu faire à travers le CLM le lien entre les populations clés et les prestataires de santé jusqu'à pouvoir positionner des points focaux populations clés dans ces centres? Merci à vous.
Yes, thank you. I understood your question, but I will answer in English for the purposes of most of the folks on the call. As I said in the chat or elsewhere, we will connect you over email with our implementation partners, Manarella in Malawi, who can answer this question in a lot more detail. I can't tell you how they selected the specific staff who became the key populations focal points themselves, but I will say from a CLM advocacy perspective, what they did do was use the data to make the point at a policy level that there's need for this level of expertise in each of the health facilities. And then that gave the mandate from a district health level to be able to give individual health facility managers the power to appoint a key populations focal point, just so that there would be an expert at each of the sites who is then responsible for management across the health facility and for the improvement of programs. But your specific question on how were they chosen and recruited, I will link you to Manarella for that specific answer.
Yeah, Krista, can I chime in? Just Yeah, I just wanted to say that the key role of the data collectors and the key role of our implementing partners in these facilities, because they are the one who are coming from the communities. And like we said, sometimes there's not even a demand because there's not even awareness of the what are we actually entitled to. So by data collectors being part of the community, they're basically also raising awareness and creating demand for services among the key populations. And that's also what's happening in 14 health facilities in Malawi. And that is how they actually said, okay, maybe we would like to have, because we are not welcomed very well when we go to receive our regular therapy. So they say we would like to have a key population, our representative focal point in these health facilities. And that's what we've noticed also with different categories, also with the sex workers. And the demand creation is actually coming from the data collectors, because sometimes they are even the very well respected, sometimes even the traditional, coming from the traditional authorities. So that is also demand creating as a part of the CLM as well. Just wanted to chime in on that. Thank you.
Yes, thank you. I can see there's another question in here in the chat with regard for access to key populations in terms of being a data collector with regard to CLM inquiries relative to children. Am I understanding that question properly?
Krista, maybe I'll chime in on this one, because we're not sure if the question is exactly that, but one thing that we can say is that in terms of data collectors, we should be okay. So it's the access of community members to key population sites or key population groups. So one thing that I can say on this is that when you're selecting your data collectors, one very, very important point is that they have to be part of the community. So if your CLM is on issues related to key populations, your data collectors, so your community actors or community data collectors should be also part of the same population. So, so there would be peers that would actually be collecting data. Otherwise, you will have problems of access because they don't know who's coming in, basically, and because they are not trusted data collectors. So I'm not sure if that answers the question, but basically, if you're collecting data on a certain population, it's the same population that's collecting the data. So I will be a gay man or man that has sex with other men, and I will be collecting data on this population. Back to you, Krista.
Thank you. Thanks, Nadia, and we hope that answered your question, but I can see lots of questions coming in on the chat now, which is very helpful. There's a question here about sustainability. What are the sustainability programs to ensure that the best practices are maintained beyond the CLM presence in the local country? I think there's kind of two questions there, actually. One is about sustainability, and one is about best practices in CLM. So I will start with the best practices question first. CLM, as we said at the beginning, is a nascent practice. ITPC has been doing this for 8 years at this point, including a very big treatment observatory program in West Africa that went on for 5 years. But overall, the practices are nascent. So that's why we began the presentation with CLM principles that have been agreed upon. But the implementation process itself does really vary. So the ITPC model we presented today with the 4 components of education, evidence, engagement, and then advocacy, that's not necessarily the model that's implemented everywhere. But this is the model that we feel is a best practice because it ensures data quality. It ensures that the data has a built-in feedback mechanism for advocacy and for change. It's not just recurring data collection that becomes a bunch of data that's interpreted but never used. But I will say there are other implementation practices So one of the challenges of best practices is that we're still defining in the literature what counts as a best practice. So we certainly have a perspective from our side. We're not saying it's the only best practice, but this is the version that we believe in. In terms of the sustainability of programs, this is a very important and ongoing question, one that we are grappling with ourselves. I'm sure many of you on the call are linked to Global Fund GC7 grant applications, many of which we understand only 2 windows have been analyzed so far, and it's already been over a 120% increase in funding for CLM as compared to the last round of Global Fund grants. And that's only the first 2 windows, and there are 5. So there's a big influx in investment in CLM, and CLM is also a funded priority for PEPFAR. But then the question comes at the end of these 3-year programs, what is the sustainability plan, and where do we think this is going? And my answer at this point is, if we can do high quality CLM implementation, then the value of that data and the value of the co-creation of solutions will become so effective that that essentially is the sustainability strategy. If the collection of partners at district level, at national level realize, wow, this information has been so helpful for us to improve our programs, to reach some of the 95 targets, to help identify, especially the barriers for key populations and why we have not been able to reach the targets that we want to achieve, then that itself is a sustainability strategy. But again, all of that hinges on the high quality implementation of CLM. I do have a bit of a fear that there will be 2 or 3 years of very strong investment of CLM and a lot of pressure to implement very quickly, but not necessarily at the highest quality. And if we have low quality implementation, then at the end of that 2-3 years of investment, there might be a feeling of, well, we invested, but we didn't get the outcomes that we needed. So just to make the case, it's important to fight for high quality implementation and to really say, these are the priorities, you know, from a KP perspective, this is what my community is saying the priorities are, and not necessarily just to implement indicators or frameworks that you might be getting pushed to take on, because communities themselves are the ones who are identifying the barriers, and that is really where we should focus our monitoring efforts. But let me open to my colleagues as well to see if there are others who want to weigh in on the sustainability question.
Yes, thank you, Krista. I'll just add on, Nadia, here, 2 things. The first one is to ensure sustainability of CLM from a purely very practical point of view. I would say integrate it as much as possible in your structure. So if it's integrated in your usual monitoring activities, in your usual programs, if it's not a separate program from all the others, then there's more of a chance that it can continue, because it will become like recurring, you know, and it will go on, even if the funding changes, even if maybe the local context changes. So as much as possible, don't think of CLM in terms of a budget with the opening a new program with a new program officers and new M&E team, and see how you can integrate it in your own structure and build your own structures capacity around CLM. And secondly, around best practices, one thing that I would also advise is, if ever there's anything that works well, either because you've advocated and there was a change, or because through the CLM data you've discovered that this practice works well, try and get it formalized as much as possible. So try and get something, some signed document or some agreement or something that formalizes it over time, so that even if the context changes, let's say opening hours have changed to adjust, and it's worked out well, try and get something official, so that if the manager of the healthcare facility changes, for example, this is documented and it will still stay in place, and you don't have to fight for it a second time 3 or 4 years later.
Thank you, Nadia. I know that we need to leave some time for reflections from all of the countries that are on the call. So I will invite one last question before we hand back to SSLN for the reflection. Maybe I'll just invite a very quick lightning round in that case for our experts on the call. Nadia, Innocent, Nadia, and Yelena, if you had one piece of advice on CLM implementation, something that you want the partners on the call to be left with, what would that piece of advice be?
Alors maybe, Krista, before we go there, I would be curious to know, because there is still 50 participants, I'm very impressed. And I know from what country you are, but if they have experience on CLM, if they are implementing or are willing to implement community land monitoring program, but it may be a little bit complicated to do that because it's already almost, we're almost done, but it was for my own, own interest. But we can do also the lightning round.
Sure. So your question was how many folks on the call are actually implementing CLM?
Yes, exactly.
Maybe we could do a raise of hands. So if you're on the call and you are currently implementing CLM, would you mind to raise your hand so we can just do a quick poll? There should be an option at the bottom of your screen that says reactions, and one option is just to raise hands. Thank you.
Okay.
I'm seeing a couple of hands being raised.
Mm-hmm.
So for the most part, it seems most people aren't implementing yet. And the majority are probably here to learn. So thanks, Nadia. That's a good question. In the meantime, let me just quickly hand over to each of the speakers on the call for just one last final intervention, very brief, and then we can hand back over for country reflections. Thanks. Maybe we'll start with, we'll go in order. So Yelena, then Nadia Perun, then Nadia Rafif, then Innocent.
Alors maybe Gaye want to intervene also. He has his hands. Maybe just before we do that. Sorry, Krista, I know you cannot see the screen and the chat at the same time. I think there is a last question from Gaye.
Gaye.
Yes, Gaye, s'il vous plaît, demandez votre question. On vous attend.
You are mute, Gaye.
Je peux parler, c'est Gaye.
Oui, s'il vous plaît.
Ok, merci bien. Je suis Gaye Mouboy Aubin Désiré, chargé de programme Population Clé, ONG Alliance Côte d'Ivoire. Et je suis champion Population Clé, SSLN au niveau de la Côte d'Ivoire. Alors, pour faire un commentaire sur le démarrage du CLM au niveau de la Côte d'Ivoire, il faut dire que nous avons démarré déjà avec l'appui de ITPC Global au niveau de Alliance Côte d'Ivoire. On a bénéficié de la formation des formateurs, des acteurs sur le CLM. Et dans le financement, avec le financement du Fonds mondial, il est prévu de former tous nos acteurs et de démarrer avec le réseau des organisations de population clés. Nous sommes dans le processus d'identification et dans ce processus, nous prévoyons recruter, identifier 8 organisations identitaires qui ne mènent pas les activités classiques, mais qui seront mis en place pour la mise en œuvre du CLM. Alors, il faut dire aussi que le point de vue que nous avons sur le CLM et après cette session, au cours de cette session de Zoom, ce qu'on peut retenir à notre niveau, c'est que, excusez-moi, j'ai un souci avec... Est-ce qu'on m'entend?
On t'entend très bien.
D'accord, ok, merci bien. J'ai cru qu'on ne m'entendait pas. Alors, donc, ce que nous retenons, c'est que le CLM, c'est bienvenu pour nous et ça nous permettra de faire une autonomisation de la communauté. Cela va renforcer le pouvoir décisionnel des populations clés et ça leur permettra aussi de participer activement à la surveillance des programmes de santé en leur direction. Sur le CLM aussi, on retient que ça améliorera la transparence en impliquant même les membres de la communauté dans la surveillance. Et aussi, elle permettra de donner des réponses aux besoins locaux Je pense que c'est ce qu'on peut retenir. Et comme plan, c'est de mettre en œuvre, toujours en synergie avec ITPC et les autres organisations qui ont déjà démarré le CLM dans leurs différents pays, c'est de continuer le partage d'expériences pour un meilleur CLM. Merci.
Merci beaucoup pour votre commentaire. We really appreciate it, sharing your experience from a local level. I will now hand back to SSLN. I know we need 10 minutes for the country reflections. So over to the SSLN team. And I apologize, I know there are still hands up, but I believe we're out of time.
Thank you, ITPC, for that very fascinating presentation. And thank you to our country champions as well for your questions and your engagement. Now, at this point, I'll be calling on our country champions to give their reflections on the presentation. May we please have a representative from Zambia share their reflections.
Okay, so thank you. Maybe I can do it. Yeah, so I think the presentation from the CLM team been excellent, and I think what we gotten from the whole discussion is that I think the CLM could be looked at as one of the approaches that or avenues that advocates for improvement of quality of health and also promotion of equity and also to ensure that the community have equal access to the services. And it was exciting to note that their intervention is not just from without, but evidence-based, which we feel is actually in line with the one of the SDGs where we want to achieve universal health access. So the efforts that have been shared so far, I think they're in line with the goal of achieving universal health coverage. I noted that some of the efforts that have been done in other countries, for example, certain barriers, financial barriers where user fees were actually removed, which is perfectly in line with the efforts to reach universal health coverage. More also, I think what we appreciate from the responses was or the guidance that the emphasis for the integration of the CLM implementation, and I think I agree with them that this way to ensure that the capacity and some of the implementation approach remains in the existing system, which will assure sustainability of the gains that have been made so far in the particularly under the HIV program. And more so, we appreciate that the CLM seem to also have a big impact or a big influence on the health system strengthening. I think we learned quite a number of interventions such as capacity building and also just issues around the governances in terms of how they engage with the various key stakeholders. I think these are some of the issues that are as a reflection from the discussion. Thank you. Unless there's another thing from Zambia would want to add. Thank you.
Thank you, Chimika and Team Zambia, for those reflections. Can I call on Humphrey Ndondo to give reflections on behalf of Team Zimbabwe?
Thank you, Madam Chair, and it's been an interesting session following through the presentation on CLM from ITPC. In Zimbabwe, we are implementing CLM that follows similar principles and around particularly the 4 pillars on education, evidence, engagement, and advocacy. And these are really important I think from our perspectives, we do value that communities need to understand their rights so that they can identify any human rights abrogation upon their pursuit of or interaction with healthcare services. And similarly, that rights holders or that duty bearers actually are capacitated to ensure that they promote and fulfill the rights of communities. So it's really a two-way pronged process to ensure that education results in action at the end of the day. Our CLM is also dually funded by us and our government. So we're receiving funding from the Global Fund and PEPFAR to support CLM. And we also have funding coming from our National AIDS Trust Fund or as a resource. So we are working particularly now to embed a CLM or to entrench it within our national policy documents like our National AIDS Strategic Plan already sent us CLM as one of the monitoring initiatives with which we want to see an end of HIV or monitor our growth towards ending HIV, as ensuring that we are hearing from communities that are disproportionately affected by the HIV epidemic. What is happening in Zimbabwe is we also have a structure that we call it the National CLM Steering Committee. Ours is particularly led by the KP community, and our leadership within the key and vulnerable nations national forum also chairs our National Steering Committee for CLM. And this is a very rare and unique opportunity because it is a structure that would literally almost mimic your Global Fund CCM. All the players, government, the ministries of health and childcare, in the HIV and AIDS TB unit, and also the TB itself. You also have the National AIDS Council represented there. You have the UN family in there. You also have partners are also part of that steering committee and networks of people living with HIV. The leadership community itself. We deliberated on this and made the point that we have everyone in the room and we try to cascade this structure at sub-national level, provincial and district level facilities where we have provincial AIDS action committees and we have district AIDS action committees that are located within the National AIDS Council, which forms for communities to meet and lead the CLM sub-national meetings and ensure accountability and local resolution of challenges. CLM. A few things that we really want to emphasize that we have also learned is that CLM is more than an advocacy platform. It is a tool for community-led solutions. So at a community level, really, we are seeing that communities are able to resolve issues and find solutions before they escalate at the national level. It is an early warning mechanism for new and re-emerging challenges. Because this happens at communities, there is opportunities to identify any upcoming issues. It could be a disease pattern, could be new patterns of challenges that communities are facing related to stigma and discrimination. Maybe there has been a change of staff or a rotation of staff or attrition of staff, and there's new staff that are not, and there's, all of a sudden different attitudes that towards KPs. Communities are quick to raise those and identify them. It is also a quality improvement tool. A lot of our KP work that we do at community level has improved in terms of feedback around friendliness. A lot of facilities have been improving based on the feedback that they are getting from communities about what they can improve in providing care for communities. We don't have time, but thank you so much. It was really an amazing learning experience. It's over.
Thank you very much, Humphrey, for sharing. I will now call upon Derek Opong from Team Ghana to share their reflections.
Thank you so very, very much for this opportunity. This presentation has been an education of a lifetime. Ghana has not been actively engaged in CLM activities, and GC7 that was submitted to the Global Fund, which will commence in 2020, for us next year. A new chapter will be open on CLM in Ghana, and with the benefit of this presentation, it's going to inform our strategy, and very soon, Ghana will be a champion in CLM in Ghana. Thank you very much. Thank you, Uba.
Thank you very much, Derek and Team Ghana. Lastly, may I please call on Gaye to share reflections on behalf of Côte d'Ivoire.
Allô, j'ai cru comprendre qu'on m'a appelé. Je crois que j'ai partagé déjà.
Yes, he was the first one to share his reflections.
Je peux faire des ajouts pour la Côte d'Ivoire.
Le docteur Adengra, je pense que le docteur Adengra pourra faire des ajouts.
Je peux?
Yes, please go ahead, Dr. Dingra.
Merci. Merci beaucoup. Merci à ITPC pour cette session d'apprentissage. La Côte d'Ivoire est engagée dans le suivi dirigé par la communauté. Et on a été accompagné par ITPC au niveau local. Et en termes de perspective, pour nous, nous avons deux financements. Un financement du Fonds mondial avec l'observatoire qui est géré par la société civile, mais qui est plus sur les aspects de droits humains en lien avec la population clé. Et puis, on a un CLM avec financement du PEPFAR qui a l'appui technique des ITPC pour pouvoir mener le suivi de certains indicateurs en lien avec la population clé. Mais ce que nous avons retenu dans cette session d'apprentissage, c'est surtout d'identifier à qui sont destinées les informations qui seront collectées. Donc, nous allons nous assurer que toutes les informations qui seront collectées, les destinataires ou les bénéficiaires de ces informations-là fassent partie du comité technique qui sera mis en place pour veiller à ce que les données, les informations issues de ces données-là soient utilisées pour des prises d'action. Aussi, nous voulons veiller à ce que les actions qui seront prises, le CLM puisse continuer à monitorer pour que nous puissions nous assurer que l'impact de ces actions est évident sur les thématiques pour lesquelles on va mettre en place le CLM. Donc, merci pour ces orientations de l'expérience du ITPC sur la vision du CLM qui vient pour enrichir nos connaissances. Merci.
Thank you, Dr. Adingra. There's also another reflection shared by Martin Zaswa in the chat. For the interest of time, may I please call up the Zoom poll, and may participants please complete the poll before you drop off the call. There's also a request from our ITPC colleagues that before we leave the meeting, we switch on our cameras and take a group photo if possible. Thank you very much.
Yes, thank you all. If you don't mind to unmute even or to turn on your cameras, even as you are filling out the poll, it will give us a chance to document that we have all been here together. This is something I always forget, and our colleagues are always reminding me. So thank you, Yelena, for reminding me this time. Oh, it's so nice to see all of your faces. Okay, I will give it 20 more seconds, and then Yelena, I think you're the screenshot expert, so I might let you take the photo.
I will do it. I will do it. Do you have some funny words, Krista? You usually have a song or a funny word to make people
Oh,
smile.
to make everyone smile? You know, I'm kind of at a loss this morning.
Okay, everybody seems to be smiling. Okay, let's go. 1, 2, 3. Okay, I'm gonna take one more. One funny one. Yay, that's the spirit. Okay, thank you all. I took a few.
Thank you, everyone. Sorry for trying to interrupt your poll with a photo opportunity, but this is the nature of community work, as I know many of you know.
Nice to see all the faces. Yes.
And just as you're completing the poll, I will just say a few closing remarks from ITPC. Thank you so much for the opportunity to speak with you today. Many of you on the call are also very expert, and we know, for example, there's been a lot of implementation of CLM in several of your countries. There's a lot of expertise here from Côte d'Ivoire, a lot of expertise from Zimbabwe as well, and some really excellent comments today from everyone who's engaged. So thanks for your level of engagement, and please don't hesitate to reach out if there's other kinds of support that we can provide. And I will hand back the closing once it is time to SSLN, but thank you again so much.
Thank you once again to the ITPC team. That was a brilliant presentation, and I am sure that our country champions on the call today found it as interesting and exciting as we did. And thank you once again to everyone who participated in this meeting. Your participation is greatly valued. Thank you all.